Started yet, right? It's
Sir,
still,
yes, sir.
yeah, it started.
Start, sir. Yes, sir.
Okay, okay. So, good morning again for all the participants here. Good morning, Dr. Charanya. And at the outset, my sincere thanks on behalf of the Department of Pediatric Dentistry and Center for Early Childhood Clinical Research. Um, I think you're also following us in these sessions over the last few months, and it just happened to be a thought process. Then we crystallized our thinking. We spoke to a few people, and I'm sure that you're doing a fantastic job in Coimbatore. Both
Thank you
the
so much.
government side, I see some of the posts here and there in terms of educating the public and also in your practice as well. So appreciate your good work and looking forward to learn a few things from you. And thank you for your time once again. And over to Vignesh. Dr. Vignesh, yeah.
Thank you very much for the opportunity, sir. And I think I met you in 2013 in Chennai before I started my practice in Chennai. I don't think so you would remember me, right?
No, no,
As
I
soon as I
remember
finished
you,
my
but
PG,
okay,
yeah,
then
I came to meet you then, and
okay.
it's been I've been inspired by the work you do a lot, sir.
Thank you,
So
thank
like
you,
so many inspirations, and I think it helps to see people who are doing wonderful work.
thank you very much. Yeah, yes, Dr. Vignesh. Yeah.
Yes, sir. Uh, so good morning, ma'am, and good morning all the participants. So today's topic for the program is 24, the golden period, and about a few words about the program. So you all know about the oral cleft status of the children who are born with the cleft lip, and we don't know about the quality of life and what are the early interventions to be done immediately after the 24 hours after the birth. And as a team member of the Cleft team, as a pediatric dentist, we should know some of the basic protocols. And as personally to me, I am not aware of more about the protocols. So today's presentation, Dr. Saranya ma'am will talk about the protocol, which was exclusively developed in the government medical college and was implemented for 150 children for the Cleft care in the first 24 hours after birth. That is the golden period ma'am is going to talk about. And also, she will emphasize the role of a pediatric dentist, how important as a team member, and also correlate the long-term outcomes about the cleft lip para children's. So, a short introduction about Dr. Saranya ma'am is ma'am is a pediatric dentist. It's an exclusive pediatric dentist and also runs a practice named as Chandra's Little Smiles at Coimbatore. And she's also an assistant professor at Coimbatore Medical College and Hospital and working as an early intervention dental specialist from 2015. And ma'am has completed a master's from Manipal Dental College in 2013 and completed undergraduation from the Ramakrishna Dental College, Coimbatore, and had participated in various hands-on and workshops and presented many papers and got many awards. To her credit, he is a gold medalist of Dr. MGR University for overall scoring highest marks from our honorable president Dr. APJ Abdul Kalam in 2010. And she got Dr. Rajamal Punnaya Endowment Award and Dr. Anil Kohli Endowment Award for Best Outgoing Student of the Year in 2009, and Dr. Rangachari Endowment Award. Hello. So, sorry for interruption, ma'am. And also, ma'am has got Dr. Rangachari Endowment Award for Gold Medal for Best Outgoing Student in Orthodontics for the year 2009. And she has won many awards and also participated in extracurricular activities. So, over to you, ma'am. Thank you for accepting our invitation. And also, you can start the presentation.
Yeah, thank you so much, Dr. Vignesh, and thank you so much, Muthu sir, for this opportunity. I would be really grateful for all the people who helped me to come all the way here, like my teachers, all the mentors. I have many mentors, I should say. So uh, that's something which brings us into the journey. Thank you so much, and now we'll start our presentation. Everybody, I would like to uh, just focus on this slide for a moment and just think in your mind what comes to your mind when you first look into the slide. If it's an interactive session, I would ask your answer, but then I will tell you what is the answer I've received from many people when I do some presentations like this or when I teach my students. So usually they see the dot. There are people who see the white screen. So there are people who see both of it. And there are some people who see that the white place is bigger than the small dot which is present in the center. But if you see the majority, like almost 80% of the time, the dot is the one where the focus falls on. It's just how the mind works. The mind works to see something which is little away from the normal or which is something different, and it focuses on the different things because it just likes different things. But if it's a child who's born with a cleft, how do you think uh, the smile of the child will affect a person who sees it? The smile might look a little different. The smile is definitely not the one we are used to, but the language the smile communicates is still the same, right? It is about the child trying to express or child trying to connect with the world. And somewhere we are the people who come into play when a child like this come into the world, and we need to have a different perspective towards these children because it's all about how we train our mind to see these kids. So this is something which has always stayed with me. Like we don't see things the way they are; we see them the way we are. And in if we want to see things differently, then probably we will have to train our mind to see things differently. So with that, I will talk about our protocol, the 24, the golden period. My journey as a pediatric dentist started in uh, Manipal University, and I landed up in 2015 in District Early Intervention Center of Coimbatore Medical College Hospital. At the same time, I started my small practice, and then now we have expanded our practice, and I'm still working in Coimbatore. In our practice, uh, very rarely we do see children with cleft lip and cleft palate or any congenital oral clefts. But when it comes to working in a tertiary care setup, there are so many children who are born with congenital defects. And if you are a member of a team in a tertiary care setup, you are supposed to and you will be forced to see children who are born with congenital defects, especially cleft lip and cleft palate. And since it's our specialty, if you are a pediatric dentist and you are put up in a position of a tertiary care team, naturally you are expected to know things about it and you are expected to help these children. But are we really trained to do that? Is another big question. Before I started working here, maybe I would say hardly there was any exposure to children who are born with congenital oral defects. And maybe there in post graduation, one or two cases where we have really worked with children with congenital cleft, that too not immediately after birth. We would see the children for giving an obturator very later in life, or some children who will need some devices, that too very later in life. So here, what we do is we do meet children who are just like present and born there. We have the NICU unit and the OG department and the dental department, that is the early intervention center, all very closely associated and working with each other with the Department of Pediatrics. So here we tend to meet a lot of children like that, and you'll be amazed to know that there are it's like 1 per 1,000 live birth. So for a month we'll have around 800 deliveries happening in our OG department. So that means like almost in 2 months we'll be seeing at least 2 to 3 children who are born with congenital oral defects, and so we need to learn how to manage them or how to be the person who are going to help them help their parents to take care of them, being a member of that team. The first 3 hours, that is the child is born, and immediately after the child is born, the first 3 hours, usually what happens is the role is played mostly by the neonatologist or the pediatrician and the nurse who is involved with helping the mother to feed the child. So infant care is like you will have a neonatologist or a pediatrician who will check the baby, They will check the baby, they look for the cry, the activity, all the vital signs, and ACAR score. That is, if the child is able to survive in this world, and is the child brought into the world well, there is no respiratory distress, is there any signs of cyanosis or things like that. So once they look out for all these things, if the child seems to be a healthy child, they will refer to a pediatric dental team as soon as the child is like wiped out and stable. If the child is not able to survive or just sustain by themselves, then the child will be taken to the NICU, which is a neonatal ICU. And if there's a ventilator support which is needed or any other feeding issues and they need support, so they will be put upon nasogastric tube intubation and they'll be fed like that. So whatever happens, the colostrum or the breast milk, which is the first breast milk which comes out of the mother, so that is somehow fed to the babies. If the baby is not able to suck on that, at least it is expressed and it's fed to the baby. So that part is taken care by the neonatology trained nurse who's available in the NICU. So once this is done, now we have to start looking out for what is the role of a pediatric dentist. Like in a primary management, we have to see for what are the things in the primary management is the feeding and the airway issues, and you have to look out for anomalies, mainly central CVS and the CNS. Usually, what happens is the cleft defect is developed. It's from the stages of development, like almost when the child is in utero, almost from the 2 weeks of development, there are many sequence of events which will be having, like the neural crest cells migrate. There is the cell migration. They will travel to a location, and there will be proliferation of cells. So they will differentiate. There are so many steps which are happening in the embryology. So all these cells are somehow interrelated to the neural crest cells. These neural crest cells migrate to various places, and all these things may be intermingling or interacting with each other, and there will be genes which are interacting with each other, and and that is what is leading to a cleft defect. So when the cleft defect happens, there might be simultaneously other systems involved, which might be ocular and ear might be affected. The heart might be affected. There will be other associated anomalies, and we should always have an eye for those anomalies. And while treating, we should know our limitation, and we should always know that whenever it comes to any congenital defect, it's usually a multidisciplinary team approach. You are a team member, so you should behave like a team member, knowing the do's and don'ts, and you should always know when to refer, when to take help from others. And most of the times, the situations are very different that you won't be the only person who will be able to manage everything. But with a lot of help, you can manage all these children effectively. When I spoke about anomalies, this is one of the paper, and anomalies in the facial region, ocular region, central nervous system. So all these anomalies have been there. But one of the main anomalies what we see with these children are cardiac anomalies. And when a cleft is associated along with a cardiac anomaly, most of the cases there is a possibility and a risk of an aspiration. So aspiration pneumonia is seen as a leading cause of death in these kind of children. So why we have to understand that aspiration may be a leading cause of death is that's why our intervention as a pediatric dentist comes into play. What can you do to help the child with an aspiration or prevent this or avoid this death? And how can you be a dynamic person in bringing about the overall wellness and growth of the child or make the child very thriving? It has a huge impact. So the outer core is the team. That is the outer circle is the team of the people who form the pediatric and dentist and nurse team in the district early intervention center. So we have a dental lab technician as a part of our team. There's a psychologist, social worker, speech and language therapist, and occupational therapist. So all these people work with the mother and the family. And once our work is done in a very effective manner, naturally the child will be next shifted to the second level of rehabilitation, which is the surgery. So surgery part to for the child to reach that part, we really need to put in a lot of effort. And when we work as a team, you have different aspects coming into play. You see things very differently because each one has an expertise in their own field. And when the expertise comes together, you have an output which is like really good. So what why the pediatric dentist should be a part of the team is something which I used to question myself. Like when I started first I started seeing these children. I had no training. I had no experience. All I had was some academic book knowledge. And when we started seeing these children, this was the question I asked myself: like, why are they expecting us to do this? And sometimes it is very scary to see a child like that, and you have to do something there. And so naturally, as a pediatric dentist, how others have understood our profession is what I would say. So you are there to help a child when there is a need for difficulty in feeding, difficulty in speech, and if there's any infection, then you would be helping them out. If there is any aesthetic problem, you'd be helping them out. But the nutritional needs of the child, that they understand that okay, caries comes and you have nutritional child is not able to feed well, then there will be a pediatric dentist who is there to help them out. But as a person who is going to help them out with the nutritional needs as an infant, uh, that's something which we don't usually think about. But what I feel we bring to this team, what a pediatric dentist aspect, how we bring that to the team is the emotional, psychological support along with the knowledge and skill which we develop to help these children. We do learn psychology for the, sorry, okay. We have psychology as an important subject for our postgraduate subject, right? So I think we are the best people to be here as an interventional dentist. We do have orthodontists who help them out, prosthodontists who help them out, but I feel like a role of a pediatric dentist could be very, very important, and it could bring a very new angle helping these children. But when it comes to the obstacles, like why we should do, oh, I mean, like how we could not do it, or how we should do it, probably we should gain a little bit more trained in helping these children. And we have to first cross the mental obstacle that I don't know cleft, I don't know what it is, and I don't know the subject. And there are a lot of myths about feeding. There are a lot of people who think that cleft children cannot be breastfed or they cannot be fed in any other method. So all these things we'll have to do some changes, and we have to obtain skills to help in assisted feeding. How to do that if the child is not able to be directly breastfed by the mother? How are you going to help them there? So this is the protocol. Like I'll explain the steps one by one. But before I explain the steps one by one, I would like to tell you like we have seen so many kids. Like almost now in the past 5 years, we have treated 150 children. So all the pictures, most of the pictures what I've used is from the children who have come to our center, and the clefts may vary very much. Like and the needs also vary very much depending on each child. The need varies. The need for feeding varies, the need for intervention varies. So there is no universal intervention thing like if it's a bilateral cleft lip, do this. If it's a cleft palate, just do this. No, it's not like that. And you need to evaluate the base, like it's like child to child basis. You need to do an individual evaluation and formulate a plan which will help that particular child. But one thing to understand basically is you have to understand the oral musculature a little bit to help these children. So when the lip is in a breach, the orbicularis oris muscle is the one which is breached up there. And when the palate is open, we have the levator palati muscles which are not working very well there. And we have some soft tissues and other muscles which are working around the oral cavity. And for feeding to happen, we do not need what to say all the muscles to be present. At least if we have some effective muscle groups working there, we can definitely work on the natural breastfeeding with these children. So before we do the feeding topic, as soon as the child is referred to you after the 3 hours from the pediatric office, if the child has come to you, you have to start talking about the most important thing that the mother is going through or the parent and the family is going through. They go through a lot of shock, and there will be shame. Most of the time they do not expect a child, because even in the prenatal screening, all the scans, they had not been informed about a child with a cleft palate or a cleft lip to be born. So it's a big shock to them, and there is guilt, and there is sorrow, and there's grief. There is huge array of emotions happening there. And when we talk to the mother or when we talk to the family, we really need to validate all those things and just not brush apart. And mothers of these children do go through a lot of postpartum depression. And we have seen mothers who find difficulty in handling this situation. And in some of the cultures, and like some of the even tribal cultures, this is seen as a taboo. Like a child who's born with a cleft lip or cleft palate, it is seen as a thing because you have done something wrong. So the child, God has uh, punished you by giving this child. So this is how it is taken. And in some of the villages, there is still female infanticide, which is associated, which is still happening, and it's a very socially important thing that's happening. And this child who's usually born with a cleft lip, for the palate is not usually visible, right? Only with the cleft lip, then it's very much visible, and it's like a stark thing which is right there in front of your eyes, and not everybody is able to accept it the way they should be. But what they don't understand is it just takes a 45-minute to 50-minute surgery to correct that defect, and the child is as good as every other kid. So making them understand this at that moment will be really tough. But then, if you are able to talk about things which the mother or the family is going through, then naturally they will be in a good therapeutic relationship with you, so that you can start talking about the next important things which are coming up. So the whole idea of all these things or the intervention, what we are doing is to bring a bond between the child and the primary caregiver. It can be the mother or it can be anybody in the family who's a primary caregiver, but we need to get the good foundation. Sometimes there might be children who are born and the mother dies immediately afterwards. So there will be some other primary caregiver who's going to take care of the child. So all these situations will be it's a kind of the similar situations, but then we will be able to give different solutions for each one. And when we talk about the bonding between the mother and the child or the primary caregiver, why we have to give so much importance to it, and why within the first 24 hours? Why can't it come little later on? There are two things which are very important. We have read about the attachment theory. And the earlier there is a bond between the caregiver and the children usually thrive well. So the bond between the mother and children is here disrupted by the fact that the child is born defective. There is a congenital defect, and the mother is usually not able to accept that. And there might be a lot of fear, and there will be like, how can I feed the child? The mouth is so open, it's so big, there is a defect. I can't give milk there. And if I give milk, milk is coming out of the mouth, the milk is coming out of the nose. How can we just feed this child? And this kind of things have to be addressed as early as possible. If that's not done at that particular moment, then later on, what happens with the child is usually the wiring happens with the feeding. I've seen children referred a little late, like maybe 10, 12 days later for any feeding assistance. What happens is the child has already got used to one method of feeding, and it finds it really difficult to switch to other methods of feeding. So if we are able to intervene at that moment and start the first feeding itself in the way we want the child to feed, or in the way the mother wants the child to feed, not we, the mother and the parent wants to take care of the child. So that will be amazing. And what we are going to do here is initially we will start examining the child intraorally. First, extraorally, we look out for all the changes, where the defect is, how bad the defect is. And once that picture is there in your mind, then you start examining the child intraorally. Like you put the child in front of you and stand in a 12 o'clock position. You ask your mother to hold the child in front of you, or any caregiver to hold the child in front of you. Stand behind the child and use a gloved index finger, and just put the index finger into the child's oral. It's very easy to say put it inside the oral cavity, But usually a newborn baby never opens the mouth. They'll be like deep sleeping or something like that. So we'll have to nibble the ears and feet and make the child open the mouth a little bit, or just do some like with your fingers, just rub the cheeks. So that's like a suckling reflex there. So they'll open the mouth, and when they open the mouth, you try to put the index finger gently inside. Slightly, you can squeeze the cheeks. It will also help it. And once inside the mouth, usually what happens is the child will start sucking. So that is the first step. Like you can check for the suckling reflex. You can check for the pressure areas, like the extent of the cleft. And submucosal cleft is something which is usually not seen by eyes, but when you feel it, like put your finger inside and feel it, make sure that all the palatal area is present for the child. So if we go posteriorly, you can see a submucosal cleft, which is usually not seen by the eyes. You can feel it. And then the pressure exerted by the oral musculature, like whether this muscle is strong or this muscle is strong or this muscle is strong around the oral musculature. You can see, you can feel the pressure areas when they do that. And also how the tongue is, like the tongue is able to move along the finger. So there's a good reflex, there's nice grip. Whether when you close the defect, the child is able to create suction. So that's a very important thing to check for. And the tension pressure areas and the bigger segment of the palate and the smaller segment of the palate in case of a complete cleft palate, which is a bigger segment or greater segment and the lesser segment. So when we are able to get one overall picture about this, then we start about discussing about the feeding options. If you have a good idea or a good feel that the child will be able to feed direct breast milk, then we have a lot of feeding positions you can try for the mother and the baby. And this will be the most effective method because it helps in growth of the palate. It helps in speech later on with the child, and it helps in a good bond between the mother and the child. But if that's not practically possible for any reason, then we have to look for the second option is breast milk feeding. That is, you express breast milk from the mother's breast, and from there you can give it to the child. And then you have other options of how you're going to give it to the child. That's where your role comes in assisted feeding. So WHO and UNICEF always recommend early initiation of breastfeeding within 1 hour of birth. But here in our center, what happens is within 1 hour of birth, the colostrum is given to the child. Later, after 3 hours, the child is referred to our dental team so that we can do some intervention there if it is needed. Or if it is not needed, we will just educate the mother and child about the breastfeeding and different feeding positions and send them back to the center to do that kind of exclusive breastfeeding for the first 6 months of life, if that is possible. And in case it's not possible for them, then probably supplementary or alternate feeding will start from 3 months. So at least for the first 3 months, we would like to do some breastfeeding. And there are a lot of studies and output research there saying that breastfeeding is definitely possible in infant with a cleft defect. And it's just the mental makeup of the, clinician like us and sometimes the parents that makes them think that it's not possible. I used to think that it's not possible before, but I have seen mothers who have been very good at breastfeeding. They find innovative ways to do it. If I teach a few techniques, they take up little more techniques and they just go ahead with that. All that we have to do is learn a little bit about breastfeeding and how it can be done. And some of the initial exclusive breastfeeding, if it's possible, it is possible mainly when there is a good relationship between the infant parent and their families. So we have to educate the family also around about the breastfeeding. We need to give a good counseling and about the various positions they have spoken about. Before talking about positions, one thing we have to understand about the feeding is it works on a positive feedback mechanism. That is, there will be a stimulus, the baby will suckle at the breast, and then there will be receptors in the brain, and there will be control center in the brain where the oxytocin is released and the breast is stimulated and the breast milk will come out. So this is a cycle, right? Nowhere in the cycle it has been told that you need a perfect mouth, a perfect oral cavity to get the milk out. I mean, to eject the milk out, definitely we need good latching, we need all the muscles to work, all the tongue to work, everything, right? But for the baby or for the mother to secrete the milk, all you need is the baby to suckle at the breast. So this is a very important thing because once the mother wants to make up in her mind that, okay, I'm going to breastfeed my child, I will be able to do this. I've seen so many mothers change from that attitude of not being able to give the milk to be able to give the milk, and breast milk being less to breast milk becoming more, and they're able to feed the child with the modified feeding techniques, of course. And if that's not possible, at least they'll be able to do a breast milk feeding. That is, they'll be able to get the milk out with the help of a pump, and they will take that and feed that to the baby. So this mental block, it comes because the mother is not able to understand the cycle. And if we are able to teach the cycle to the mother becomes confident and they will start doing that. And usually, for a flow to establish, it will take 48 to 72 hours. So till that time, we have to be a little bit patient and do not expect the mother to be like immediately able to breastfeed the child. That's not going to happen. It's going to take it some time and practice because even for the mother, it's all new. And the mental status of the mother, that is, if the mother is too depressed or having going through a depression, then also the breast milk feeding and breastfeeding gets affected. The nutrition of the mother matters. So all these things have to be addressed there. And the weight gain, what you're expecting is 30 grams per day. The feeding quantity for the infant should be like as much the infant needs it, you should be able to feed that. So the weight gain, if it's going to be good and the urine output is good and the child looks healthy, the skin is not dehydrated, these things make sure that these are signs that the breastfeeding is going on effectively. And these are some of the methods or the various positions we use to teach the breastfeeding. So if it's a bottle feeding, you want to try to do a cleft baby, there are specialized bottles, then it has to be always in this kind of upright position. And if you are trying to do a breastfeeding, these three positions are really good. Um, we usually recommend the sitting position or try to make the child kneel down on your lap and then try to breastfeed with the head straight. So this is the most common position we try to tell. It's called a side sitting position. But we can also do this and this types of cross cradle and football hold. And if there is a palatal defect, a mild or small palatal defect, or alveolar defect alone, even using a finger to close the defect and trying to breastfeed has worked for many children. So this is another small technique which we can use there. When breastfeeding is not possible, then we help them out in assisted feeding. For assisted feeding, there are a lot of bottles which are like teats and nipples, which are a little different, where the expression, the milk need not be sucked in. You can just press the bottle head, so the milk flows at a constant rate and the child is able to drink that milk. But our traditional method of using this palada, or what we call a sang, that has been an extremely successful method. And I still think, like, how did our ancestor, I don't know, they found out a device like this which is perfectly been made for helping children with difficulties in feeding. So this is what we try to use it in our setup, the palada, what we call it, or spoon, if it's not available, spoon or syringes, along with assisted methods. So when we're working with the mother, staying non-judgmental to the difficulties of mother is very important. That if the mother is not able to breastfeed, so we should not assume that there's something wrong with the mother not trying enough. So with that attitude, if you're able to move forward, you're definitely able to help them out. So when they're not able to do usual methods of feeding, then we'll go for feeding plate. That is the fabrication of a feeding plate. So this method of making an impression and making a feeding plate, there are a lot of controversies related to that. I mean, some of the papers and some of the studies say that there is no point in giving the feeding plate. There are some of the studies which are very much for it, but we have come to a conclusion after treating many children that it helps a few people, some children, and it's not needed in many cases when the mother is able to do modified breastfeeding techniques. But most of the time, it helps us in bridging that gap, bridging that fear that what if the milk comes out of the nose? What if the milk comes out of the mouth and I'm not able to feed my child? The ear infections, these kind of issues, when they are there, that is where this feeding plate comes into play. And the technique which we use here is we use spoons as an impression tray. We have teaspoon, tablespoon, different head sizes, And depending on the defect and the child's ability to open the mouth, we select the tray. So that is our tray. And we put the impression compound or the putty impression, whichever material is available. And then we put it in the child's mouth. We make the child open their mouth, and a gauze is usually placed over the impression material so that the material is not pushed into the defect or into the pharynx region. Always have suction around. So in case something goes in, or some material gets stuck somewhere, it's helpful. But usually with a low fusing impression compound or putty, that tearing doesn't happen. It happens with alginate, so we usually try to avoid alginate as much as possible. And once the impression is done, you have to make sure that there is no material left in the oral cavity. Just have a quick look for that. And the most important thing here is this is a very difficult step for many people to do it, because taking an impression on a cleft child and with that kind of defect, we are not usually trained with. But it is a very simple technique if you use a spoon, and do not look out for having a perfect impression covering all the areas, because the type of feeding plate which we are suggesting is not a NAM plate or a feeding plate with good border suction. No, this is a little bit of a modification from that. And I don't know, this videos running. So this is the impression making technique which we use, where we make sure that the tissues are little okay. I mean, the child is made to cry, and we put the impression material inside and make an impression and take it out. So the only the defect is covered here, and that's enough. And this method of using the spoon has been mentioned in some of the articles previously. I found the modified one here, like you cut out the window there so that if you use an alginate, it is better retained there. And this is the usual type of feeding plate which we see in many articles, and which is usually recommended, which has two fangs like this, and there is a band which can be tied to the fangs, and it will be retained into the oral cavity. But the type of feeding plate we are trying to do is little different from that. It has, when we make the impression, this is the usual border of impression, right? So this is the sulcus area, and this is where usually an obturator or a feeding plate should rest. But what we try to do most of the times is we try to stop it with the ridges, cover the defect, and stop the plate at the ridges till the suction is really good. And this is like a 0.8 mm stainless steel wire we used to make an arm like this. And the idea of what we're trying to do is, if a child is in a nasogastric tube feeding, just imagine how tedious and difficult it is for the mother or the people around to see that every time the child has to feed, you have to put the syringe and inject it and drink like that. But if you are able to remove that tube by just doing a small appliance like this, it makes a lot of difference. And our focus should be on the functionality of the device, and not the perfection. Like, we don't want the ridges and edges, nothing like that. All we need is a small plate which will close the defect, which will help the child feed a little better than how it is feeding before. So this is an example of the child feeding. I think this was done at 4 hours after birth. Immediately, as soon as the child was referred, we were able to do this appliance here. And in this child, there's a cleft of the lip and the palate. The previous baby had just a cleft palate. So sometimes when it happens like this, what we do is we try to use a syringe, and we like to train the parent, just hold the appliance with one hand and use the syringe. Most of the times what happens is the child will learn to keep the appliance in mouth even without anybody externally holding the appliance. And this type of feeding helps the quantity of milk to be going inside the mouth without coming out or through the nose. So that makes a difference in the child and the caregiver view of the taking care of the child. So after this is done, we recall the patient the next 6 hours, after 6 hours or within 12 hours. So this time is used for training the caregiver again and again to retraining them to use the feeding plate in a proper manner. So insertion, we talk about how it is retained, how you don't have to hold the plate all the time, and then removing the feeding plate, how it is done without hurting the baby, and then you store it. This is usually done with acrylic. What we give them is it's not a heat cure. We give them a cold cure because most of the times it's just a bridging thing. And within a month or two, most of the mothers are able to breastfeed. And if that's not possible, they find a way to use breast milk feeding even without the feeding plate. The fear is overcome, so they will be able to feed even without the feeding plate. So this happens here, and maybe some of the mothers use syringe. And the output, what we have seen is when there is a obturator along with good education about how we have to feed, the result of growth is, that is the growth what we are expecting for the surgery. You need the child to be of a particular weight, of having a particular nutritional status. There should be no anemia. So these kind of things are taken care of. And another additional thing what we have seen is this children develop lesser ear infections. So that's an added advantage for us, and they thrive better. Aspiration is less, and aspiration pneumonia complications related to are much, much, much lesser. And the fatigue, that usual breastfeeding and the amount of effort the child takes to feed normally with a cleft, that is very, very, very much reduced in this method. And the total duration of feeding, normally the expectation is half an hour of feeding. So just imagine every 2 hours you have to feed the child for half an hour. That's a really long time and it takes a lot of effort. If that can be reduced to a child, like a normal child feeding, it makes a huge impact on that what to say, effort you are put by the mother and the child and the caregiver to take care of the child. Okay. So this is a picture of video to train how to remove the obturator. And you can see the child is just holding it inside. Okay. So the child is able to hold it inside. They have a lot of other retention muscles working there to hold the thing inside. And after this, we call them for a review. So that's a 12-hour review. And after 12 hours, we call them for reviewing if there is any areas of redness or pressure points and how the ease of feeding is there. If the mother is able to feed and if there's any other difficulties, we discuss about the difficulties and we assess the duration for feeding. Like, sorry. Yeah, we assess the feeding duration for them. We use a clock to see that how fast the feeding is going on, whether they're able to do it the way we are expecting them to do it, and how to store it, whether storing is good. And this is the mother who is able to do that within the, I think within 12 hours, I think this video was taken within 12 hours, I think. So it makes a difference. It makes a difference. And it makes a difference to the mother in the way that they feel like this problem can be sorted out. And when all this has happened, only then do we talk about the surgery aspects. We document everything in the case sheet about what we have done and what are the instructions we have given and the danger signs of aspiration, what they have to look out for, any cyanosis or any breathlessness, any difficulty in breathing. So they have to look out for all the danger signs, and if they find anything like that, immediately they will have to attend or go to a nearby caregiver, who's a nurse or a doctor. They have to go and meet a person like that. So we document all the instructions we give. We document all the appliances or the modified feeding methods we have taught to the children. And about the when we talk about surgery, we need to make sure that the growth is up to mark. And how do we track that is we use the IEP Growth Chart app. So this app is available in all your Play stores. You can just download that. Not only for these children, it helps in other children, like your older kids. Even the older children who come to your practice, you can just put in the details like what is their weight, what is their height, and you can always have it tracked. So when they come for the next visit, you can just take that and show it to them. Your child is improving. So that is a visual reminder to the parent. Okay, the child is getting better and we have to do the same thing again. So the child is going to reach the place where we'll be able to take them to surgery. And when we talk about surgery, we have to keep the expectation, we have to give them realistic expectations and it has to be communicated well. So for there's some kind of weight gain, what they expect in our center. So we have a weight gain expectation of around 4.5 to 5 kg for a cleft lip surgery to be completed. And for a cleft palate surgery, they follow the rule of 10. And this is in our center, but it might vary center to center. And the other corrections like a nasoalveolar molding or surgical correction of nose, cleft orthodontics. So it's going to be a long, long-term plan for the child. And for making that long-term plan happen, you should need a good foundation and you should need a good therapeutic relationship. Just imagine you won't go out and asking opinions to people whom you don't know, right? We usually go and ask opinions or take instructions from people whom we know, whom we trust. If we are able to help them get that trust by doing this base level of work, that's where the foundation can be built up on all the other levels of work which is needed for the child. And from the dental care aspect, after the first 12-hour thing is done, we add the parents to a WhatsApp group. And this WhatsApp group has the previous cleft children parents, cleft treated children parents, like where some of the children surgeries completed, some surgeries yet to be done. Some of the children have started speaking, some of the children have started going to school also. So it's like 5 years of follow-up. So when this WhatsApp group, when these parents are added, they ask doubts to each other, they communicate with each other, and this has brought up a big change. More than us saying, if there is a person who's already affected and they're able to tell about their experience and what has to be done for the children, the parents listen much better. So the dental care aspect, what we do is we do diet counseling from 3 months, and that's where the caries prevention also starts, right, as early as possible. So we talk about all that when our children come back for the visits, and we do teach them some of the exercises, so that has helped us prevent arch collapse in most of the children. We don't have studies to prove that, so but we have a lot of information in some of the cleft books related to that, and we're still trying that out. And any early intervention and rehabilitation possible, and orthodontics. So this is our area of care. And the allied care, usually these children have some hearing impairment, or they might be having congenital hearing loss. So, and retinopathy of prematurity. Most of the babies with cleft might also be premature. So then you will have to look out for the screening of retinopathy of prematurity, ROP screening, which is very, very, very important, because if it is identified late, the child will lose their eyesight. And it's very easy to do, even you can do it. As soon as you, whenever you're checking for the cleft, you can just put the baby in your hand and move the head, tilt the head a little down. The child will just open the eyes and look out for any white or red spot in the eye. So that's a simple method of screening. And if you find something weird, just look, refer them, or tell them that you have to check their eyes and ears also as early as possible, and get an echo done as early as possible. If you're not you're seeing the child in your clinic, then definitely you have to give them this information and make sure they are doing developmental screening as early as possible. So this is some of the myofunctional therapy exercises we try to teach the child. And this child is a post-cleft lip repair child with a mild alveolar defect present. But the arch collapse has not happened when the parent has been doing this exercise properly. The arch collapse has not happened. So it's really nice when we see children coming back with no caries, no arch collapse, and nice form faces. So that gives you a lot of happiness. When we talk about what outcome as protocol, our protocol has brought out, these are the things which I really wanted to focus on. It decreases the risk of aspiration and death. That's a very, very important thing. Prevention is like the most important thing what you can do for a child, and it prevents death in many cases. And the attachment between the child and mother. So some of the children or some of the parents who have identified that the child has had a cleft lip and palate in their prenatal scans, they have been given counseling. So when the child is born, they are a little bit prepared that the child is born with a defect and their idea is completely different. But when there are parents who don't understand that and the child is born with a defect, it's like a huge shock, and sometimes they don't want the child. Sometimes they just want to leave the child in some orphanage, or some people even go to the extent of not feeding the child so that the child dies on their own. Okay, so that I've seen these things happening, and that's where the interest came to why we have to really educate them. So this is important here, and the bond established between the child and primary caregiver is very important for future mental health. And the therapeutic relationship of the team is the foundation of success in the long term care. And the surgical outcomes of in the long term growth is also good if you're able to establish this 24-hour protocol and good bonding there. So our protocol has been implemented in the Coimbatore Medical College Hospital, and over 150 children we have treated them successfully. And this is a average weight gain of 100 children whom we have taken, and this protocol has been followed. Uh, you can see the children look very healthy and they are ready for surgery at the right age. So we have taken up for surgery, and we have a pediatric surgery unit, a plastic surgery unit, and a dental oromaxillofacial surgery unit who have helped us in all these cases. So some fantastic outcomes, and these are amazing. And working with all these children, they've always taught us to see things very differently. Like there might be a lot of adversities, but then the way they overcome that, and the hope the parents have on all these children, and the faith they have on us, they believe that we can help them. So, if we want to care for these children, we can start caring for these children, and that will bring all the difference. And we don't have to be really too much trained or educated. All we have to think about is probably, I will take care of this child, and somehow you will find ways to do that. So, I would like to end this presentation with my all time favorite quote. And Dr. Ashwin Rao is the one person who keeps pushing me to do things which I'm sometimes afraid of doing. And this is the quote which we started doing as a postgraduate student. We did a presentation, and this was something I'm just sticking on from that time to now. And it makes all sense. And this is the baby whom I said, no, they were about at the verge of female infanticide for this baby, and this child had a bilateral cleft lip and cleft palate, and the baby turned out to be such a beautiful child. And this child made me take up this journey of working with cleft children. Thank you so much, and I'm very thankful for my friends and family who always stood by me to do things which I wanted to do, and my mentors in infant mental health, Dr. Porpave, Dr. Vibay, who have made a huge impact in my mind. The way I see the mental health of a child or the developing mental health of a child, and Dr. Aarti Rao, who's my guide, and Dr. Ashwin Rao, who's like just keeps pushing me to do things. And all my undergraduate teachers and my team at CMCH, from whom I've learned a lot, prosthodontic professor Dr. Barney, and our HOD Dr. Jai Kailash, and they have been a huge support. And the Department of Pediatrics, who always believe in things that we are able to do better for a child, the neonatology unit, and the DIC team. I have a wonderful lab technician, Vineet, who is like the person to go to, and I've trained him to even counsel the parents before I talk to them. My colleagues and Pedo Buddies group, I think I've learned a lot from there. And Dr. Gayatri Moge, I would say, I think she's doing amazing job with cleft children. And I met her in 2017 in one of the conferences. I spoke to her about all these things which she's doing, and she's been an inspiration for this kind of work. Thank you so much, everyone. And if there are any questions, we'll go ahead with that.
Thank you, ma'am.
I think I should stop presenting.
Yes, ma'am. You can switch off.
Sitan?
Yes, ma'am.
Dr. Vignesh, you can take the questions. I'll come at the end.
Yes, sir. Okay.
Questions and some comments. I'll listen to the questions and then I'll come at the end. Okay?
Yes, sir. Okay, sir. Yes. Any questions from the participants?
Hello.
Hello. Yeah.
Yeah, please.
Good.
Yes, Dr.
Good.
Bhavya.
Good morning, ma'am. Ma'am,
Good
thank you for
morning.
the presentation. I just have one doubt, ma'am.
Yeah.
What is your view on the effect of growth? Is growth affected by the placement of an obturator, ma'am?
Um, Growth
Because
effect.
since
Yeah,
because we
the
are putting
normal obturator, what we normally give, that is the NAM plate or the obturator, which covers the whole of maxilla. So that includes the ridges, right? We include the ridges, we include the sulcus, everything. The modified plate, what we use is just a feeding plate. It's not like a complete obturator covering the whole of maxilla. That's not happening here. We cover the defect, and our focus is mainly the defect. And most of the times, we try to use it as a bridge to shift from feeding with the express breast milk to breast milk. Most of the times. So
okay,
this does not affect the growth or the expansion of the plate.
yeah,
In fact, we want to happen. We want the growth to happen well. That's why we're
yes,
saying we want to do the breastfeeding or any other method of feeding. And sometimes what we do is even after using the obturator feeding plate, almost every case we ask the mother to suckle, make the child suckle to the breast. So the
okay,
positive feedback also will be happening, and the growth also will be maintained like how it has to be.
okay, ma'am. Okay, thank you, ma'am.
Thank you.
Oh, ma'am, I have one small doubt, ma'am.
Yeah,
This obturator will have that handle, no, ma'am. You
yeah,
showed one with the wire kind of handle. And
yeah.
if it's always a wire kind of handle, or it will differ the handle types, ma'am, or it
Uh,
will
I
be
mean,
very
which
handle.
one are you referring to? Like the one I showed from
Feeding plates.
two fangs, right?
Yes, yes.
No, no. The one which we do is always the loop kind of thing. So it's not a wire or there are no sharp edges extending outside. It's just a loop, and we can just hold the loop uh, like your impression tray. You have a loop, right? So you can just hold the loop,
Yes.
put it inside, and take it out. It's as simple as that. So there'll be no hooking margins, and it's very easy to clean the handle also.
Okay. Okay.
Good morning, ma'am.
Good morning, Dr. Anita.
Ma'am, the material of choice for impression only the putty, ma'am.
No, we use the impression compound also. And see, we are a government institute, and sometimes when we don't have funds, we will move to having an impression compound. And impression compound is the one which has been like used earlier on for impressions with cleft children. Like when the putty was not there, also the impressions had been made. And some people use even wax as a primary impression. And our choice is usually impression compound or putty.
Okay, ma'am.
Putty is easier.
Thank you,
So
ma'am.
if you're a beginner, putty is easier. Impression needs a little bit more training, but putty is comparatively very easy to make an impression.
Yes, ma'am. Thank you, ma'am.
Yeah.
Any other question from PGs?
Good morning, ma'am.
Yeah. Yes, Dr. Harvi.
Ma'am,
Harshit.
yes, ma'am. So, how long will the feeding plate be used, ma'am? Should it be changed often, ma'am?
We haven't like for a cleft lip child or initial like only cleft lip is present. Most of the time, feeding plate is not needed. But if it's a cleft palate child, must most of the time like a complete cleft, then there's a need for feeding plate. And for a cleft lip and palate combined, when it is there, after the lip surgery is done, we usually go for a new appliance. So first 3 months, after first 3 months, we usually go for a new appliance because once the lip is closed, sometimes the internal the configuration changes a little bit, and when the lip is open, usually the defect, the extension of the feeding plate will have it till the defect. So once the lip is closed, then we'll do another new one. Most of the time, it's just 1 or 2 times, and uh, to my surprise, actually, I was initially thinking we have to keep doing this plates. What happens is the parents learn to feed the child even without the plate, so they get that confidence, and even little bit milk comes out of the nose, nothing is going to happen. So you have to teach them that nothing will happen. things happen when the child is aspiration happens, right? Early on, when you don't know how to feed, when there is like initial dilemma about feeding, that's when the aspiration happens very frequently. So if you're able to tide over those months, then you can just go ahead with simple breastfeeding techniques also. I've seen solids being fed like that also. Like you use a bottle with a bigger hole and they give purees and solids just like that without any problem. When
Yes,
they
ma'am. Thank you.
switch over, right? That also happens.
Yes, ma'am. Thank you.
Yeah, welcome.
Good morning, ma'am. Thank you for the presentation.
Thank you,
I
Dr.
have, how do we manage aspiration, ma'am? What instructions do we give the parents to manage aspiration?
Always when we feed, your head has to be in 45 degrees. Like even if you're doing express breast milk feeding or direct breast milk feeding, we try to put the child in upright position. The head has to be, if it's a direct breastfeeding, we tell the head has to be directly in front of the breast. Okay, like this, you have to keep the head directly in front of the breast or keep the child in an upright position as much as possible. While feeding through other assisted methods, it's 45-degree angle. Like you keep the child in 45-degree angle and it prevents the aspiration. Once the feed is over, you have to burp the child. So burping may take a little longer because these children usually suck air also along with milk. So it takes a little longer. Make sure that the burping is happening properly and to put the child in position. Like when you put the child to sleep also, maybe initially you can try to put them in a little side position, then go for proper back sleeping position.
Okay, ma'am. Thank you.
Uh, so sorry, sir. I just want information I have to pass it on. So all the participants, I just posted the feedback form link in the chat box. So those who have questions can ask, or if they don't have any questions, they can just fill the Google feedback form. Any other questions from the participants side?
Okay, Vignesh, can I then? I think
Yes,
looks
sir.
like
Yes,
there are no questions. Okay.
yes, sir.
Thank you, Dr. Charanya. It's
Thank you
wonderful
so much, sir.
listening to you, and
It's been a
I
pleasure to talk to all of you.
it's the first thing what I would like to comment or say is I was trying to note it down, but before that the slide changed actually. What you
Okay.
have written there, pediatric, in your first slide, where you're pediatric child and or maternal health professional. What have you written there?
Child and adolescent mental health professional and pediatric dentist, sir.
That's exactly the child and adolescent.
Mental health professional. I have done a postgraduate diploma in child and adolescent mental health after this, and right now I'm being mentored by an infant mental health psychiatrist, Dr. Vibay. He's in
Okay.
Australia, so he's my mentor
Okay.
now.
Child and adolescent mental health or maternal?
Mental health specialist.
Mental health. Okay. Okay.
And I'm pursuing my counseling and family therapy postgraduate diploma right now.
Fantastic, fantastic.
Thank
Many
you.
more to come, and I like the see because usually I know oral medicine senior, one of my senior. He used to call. He doesn't. He never used to consider that oral medicine as a non-clinical specialty. He always says himself he's a oral
Yes.
physician.
Yeah.
Okay, so that's what the pediatric dentist, you we can take up so many different dimensions or role. The scope is basically around the interest of the individual, right? So it's
Yeah.
amazing to see that you are focusing into something in that area, and it's and the work what you're doing. And as you rightly said, after Gayatri Moge, you are the second person I'm seeing who are
Oh,
working
thank you
and
so much.
not and
That's a huge credit. Thank you.
if you're not a member of ICPLA, you have to become soon. If you're not, so look for that. I think Sansit Paul is there, and couple of
Sanchit keeps
handful of people.
saying that, sir. You have to be there, sir, and you
Handful of
have to
people are
be.
there. There are
Yeah.
3 or 4, 5 pediatric dentists are there. So you look at that as well, because when you have 800 deliveries happening in a month, okay,
Yeah.
I look at whenever you have this kind of number, as a researcher, you look at 10,000 people in a year. right?
Exactly.
It's 10,000 subjects in a year. So you
Yeah.
do any small thing in terms of research, it can be a huge sample size and a phenomenal contribution to science. It can happen that way. Okay, that's a great, and I'm sure that you have a good team based on all specialities covered there. You have a good dental team, good medical team, and all the team. So I think the probably you should look at documenting and going transforming or preserving this information for a longer
So
for a long term.
we are
Yeah.
trying to implement this protocol in all DICs of Tamil Nadu. So for now, we are
Okay.
working towards that.
See, what happens is whenever you want to define or design protocols or guide things like that, the first thing we should try to document what we're doing.
Document.
Okay,
Yeah.
and that needs a certain amount of training and
Yeah.
learning,
Yeah.
right? To do it in the
Exactly.
best possible journals, and we have come that journey. Okay,
Yeah.
so we can. So that's a great possibility for you. And one of the simplest and the best thing I picked up from this, I have taken impressions for cleft lip and palate infants when I was a master's degree student in Bombay. We have made some feeding plates and all. And but in the Ramchandra University, they don't do these plates with the cleft department because they don't believe in the plates or
Yeah.
till recently. But now
Yeah.
they are looking at it in a different way. So this experience of taking an impression compound and struggling to make an acrylic tray, all these things, the biggest simplest thing what I picked is you can use a spoon, right?
Yeah.
And putty. I never knew this. It's amazing. I'm telling you, that's one point which is a big takeaway for me. You just need a stainless steel spoon
Yeah. All
and
you
we
need is
have putty all the
that.
way. Because the amount of time and energy we have spent in making these acrylic plates, I'm telling you, it's we make a preliminary impression, develop a plate, and in
Yeah.
that you put again impression compound, take a final impression so that you get as much as the
I picked this up from the technician, actually, dental technician who was here. But then
uh,
he was taught by Dr. Bharani. I just spoke to him yesterday about it. Then he said that he was taught by Dr. Prasad. So,
okay.
and then I was telling sir, probably we should publish it somewhere.
Yeah. So and also you put some articles on that, right? Somebody have
Yeah.
already spoon as a
That was like
then
a modified one, but this method what we are using is just simple plain spoon. Take a spoon, ask the
yes.
patient to bring a spoon, that's all.
Exactly. I'm just thinking now. See, I wish I had known this so many years back. I would have taken
Yeah.
definitely certain number of impression with a spoon without struggling to make, and that the infant also struggles to take more than
Yeah.
one impression.
Yeah.
And when you use the impression compound, sometimes it, when you take it out, it kind of changes the certain position, right? So putty is a fantastic thing. So it's a brilliant idea. That's a brilliant takeaway for me. And I think you're doing a fantastic job. Thank you for your time. And
Thank you so much,
really,
sir.
real pleasure listening to you. Definitely learned a lot. And as you're widening into the pediatric, little beyond pediatric dentistry, I think that's a big message for all the young pediatric dentists or who are all there in the webinar now. There's so much scope in terms of is there in pediatric dentistry. You can just spread your wings in multiple different domains. Being a pediatric dentist, move away from only not stainless steel crowns and pit and
Yeah.
porcelains.
Yeah.
It's so much more in the specialties there. And I wish and hope that many more people take up different areas and spreads the wings of pediatric dentistry. Thank you very much for your time. Okay, appreciate it.
Thank you very much. And it's
Sure.
been such a great pleasure to be with all of you this morning. And I hope, sir, they take away a few things from what we have told and they implement it. Even one or two ideas will make a difference. And even the way they talk to a parent will make a huge difference as far as cleft is concerned. If you're not able to do anything else, just speak nicely to them and give them that initial counseling. That makes a huge difference.
Yes.
Thank you. Okay.
Thank you.
Dr. Vignesh? Yeah.
Yes,
Thank
sir.
you, Dr. Saranya.
Yes.
Okay.
Yes, sir.
You can
I'll take
give the
it.
certificate. Yeah.
Yes, sir. Thank you for the presentation, ma'am. And yesterday during the trial, and as I said, sir also saying about the spoon technique.
Yeah.
Yesterday only I had also seen about the various type of spoons which we use for taking impression. We don't follow a first 24-hour golden period what we explained in the presentation. We try to implement. That's what we do from the Chat with Champion Buddies lecture. We take away message and try to implement in the department. So we're just trying to impart, and definitely we'll have a word with you while implementing some things regarding the cleft. Thank you, ma'am. If any doubts, I'll just call back to you.
Yeah.
Sure, yes, ma'am. I'll just share the certificate alone, ma'am. The hard copy of the certificate, I'll just courier to you.
Sure. Thank
Yes,
you
ma'am.
so much, Vignesh. Thanks for coordinating and making it like a very smooth transition.
Sure, yes, ma'am. Ma'am, this is the certificate will be printed and it will be couriered to you, ma'am.
Yeah,
By
thank you.
it will be received by you. And thank you for the time and thank you for the presentation, ma'am.
Yeah. See you.
And thanks for the textbook which I shared. I'll share to our department colleagues. And
That was shared to me by one of my colleagues, Dr. Vinod. I don't know. He's a pediatric dentist in Chennai. He's also in one of the DEICs, working in DEIC. He's
Okay.
like a go-to person for all this knowledge. And Dr. Preeti, she helps me with many research. There are a lot of people helping me with things. So yeah, you can share them and the credits to them, Dr. Vinod mainly.
Yes, ma'am. Thank you. Thanks
Yeah.
for sharing, ma'am. Thank you. Have a
Bye.
good. Thank you, ma'am. Thank you. Have a good day.
Thank you, sir. Bye.